Hey, y'all, welcome to another Active Health podcast where we talk all things health, fitness, and performance, and where we believe in taking an active role in your overall health. I just sat down with Dr. Buzz, Dr. Roy Korth, a mentor of mine that I met about 18 months ago. He is a heavy hitter in the area of regenerative medicine. He has had clinics of his own, and he has started companies within regenerative medicine, and both companies and labs that produce products to help us produce our PRP, A2M, and umbilical cord products, and even peptides. So he has a team of scientists and labs that is helping create and be on the forefront of all of these issues of regenerative medicine. And we had a chance to sit down today and discuss A2M and the overall treatment plan and how A2M is a big part of the regenerative medicine. We touch on some other topics, but A2M, alpha-2 macroglobulin, is the main subject of discussion here. I hope you really enjoy this podcast and our time together with Dr. Buzz. And we hope that we have more conversations like this with him in the future, because he's just a plethora of information in this regenerative medicine space. So I hope you enjoy this episode with Dr. Buzz. Dr. Buzz, thank you for being here with us today.
Yeah, I'm excited to be here.
Absolutely, man. We met about almost a year and a half ago, and you were speaking at an event we went to. We take our providers to different seminars to always make sure we're on the cutting edge technology. And you were presenting on a topic around regenerative medicine in both areas that we're working on. You were presenting on that particular day on A2M, and something we hadn't been doing yet and that we are doing now. So, first and foremost, let's just jump right into A2M. We can get into other stuff later, but what in the heck is A2M?
Yeah, A2M is the short verbiage for alpha-2 macroglobulin, which is a big word, right? Yeah. But to keep it really simple, it's a protein. It's a protein that's in your blood. It's actually the largest circulating protein in your venous system. And what's unique about that protein is it's a broad-based protease inhibitor. So it's another big word, protease, right? So I'm gonna dumb this down. So what are proteases? Well, proteases are another protein that your body uses to clean up damage. And that becomes problematic in anybody who has any type of arthritis, whether you've been diagnosed with osteoarthritis, degenerative joint disease, rheumatoid arthritis. All arthritis are caused by proteases. And those proteases that cause arthritis are really just a natural reaction of the body. Okay, so basically, I'll give you a good example. So, which we see quite often because we do a lot of knee arthritis, and I think you see that too, because it's very common, right? Yeah. And we'll say, here's a typical arthritis patient. Patient comes in, they're 50 years old, they were active, not active, whatever, and you'll do a history on them, and they either had a history that had meniscus surgery in the past, played sports when they were younger, maybe ACL tear or something like that, and they did good after the surgery. But now they're, in their 40s, 50s, 60s, and they present with this arthritis. So what causes arthritis? Well, what happens is when you have any type of trauma to any area of the body, and we'll talk about joints here, right? Your body, the first thing that happens is your body releases another protein called cytokines. And think of cytokines, those are just signaling molecules that cause pain. Right. But once again, the body's perfect. The reason your body gives you pain, which you don't like, is it's like your check engine light in your car. Like you wouldn't buy a car without check engine light or gauges, right? Right. So the cytokines are released, and that tells you, hey, don't go running on that knee today because you just did something to it yesterday. You need to let it heal. Okay. Now the problem is most people don't listen to the pain, and they try to get rid of the pain, and then they go do what they shouldn't be doing, what causes more damage. It's like putting duct tape over your check engine light. But I guess that's a separate conversation.
Right. Right. People don't always do what's best for them.
If something hurts, you can't, I always tell people, you can't train through pain. You can't work through pain. Right. Pain's a warning something's wrong. And, a pain for a few days is okay. But if you have pain that lasts more than, we'll say, 4 weeks, there's a problem there, and it's probably not going to fix itself. Yeah. And that's when these degenerative changes start to happen. And because anybody with chronic pain, if it goes untreated, will always develop into arthritis, and this is why. And that's whether your shoulder, your knee, your hip, your back, wherever it's at. Yep. So if you're listening to this podcast and you've had pain somewhere more than a month, or we'll say years, you will have arthritis or degenerative joint disease. You will, if you don't do something about it. It's that simple.
So what happens? It's actually, go ahead.
So your body's releasing those cytokines. Hey, there's something wrong. Hey, there's something wrong. Hey, there's something wrong. Hey, there's something wrong.
It's the flash of the check engine light.
Correct. That's the cytokines.
Yep.
But then when your body does that, your body also, remember, your body is self-healing. And if you doubt that, if you got cut, would your cut heal? If you break a bone, a bone heal? I mean, it's a miracle, right? There has to be a higher power. It didn't happen by chance, but that's a separate conversation too.
Yeah.
Your body also releases this protein called proteases. And those proteases are like little termites. But the reason that releases those is it's to clean up the damage.
Right.
So once again, you tweak your knee, you smash your knee or something, or your shoulder, whatever.
Or have surgery.
Cytokines released. So to warn you, hey, don't use it. And if it doesn't get better, you need to go to the mechanic or you need to go to your doctor to figure out what's going on. And make sure the mechanic doesn't just put duct tape over the check engine light. Make sure he does something to fix it.
Correct.
Okay.
Yep.
But it also starts to release these proteases into the joint. And the reason it releases the proteases is those are there to clean up the damage.
Right.
Okay. So those proteases are in there and they're cleaning up damage, which is a good thing at the time. This becomes problematic, though, as we get older, because once we get past between 30 and 35 years of age, your body, your joints become avascular. They don't circulate well. And those proteases are really large proteins. So those large proteins that are released to clean up damage, if they continue being released because you have chronic pain over months or years, think of that as a bunch of termites in the joint. They slowly start to eat away at the synovial fluid and cartilage. That's the cause of arthritis. It's the proteases. It's not because you're getting older. It's because your body's released those proteases to clean up damage because you keep having pain in the area.
Correct.
Okay. Whatever the arthritis is.
And so in a typical inflammatory cycle, you injure yourself, you get the cytokines that's starting to go to the area, cause the inflammatory cycle, and then you got the proteases that are starting to clean it up. And it's actually those proteases, part of the cleanup process, that's starting to lead to the arthritis. Thus, in comes A2M, right?
Correct.
Yeah.
So when you have proteases in the joint, so let's go what a typical person would do. So you have knee pain, standard course of care. Do you go to your doctor? Hey, take some NSAIDs or ibuprofen, or we'll start with NSAIDs, which are like ibuprofen, Advil, and those block the pain signal. They do nothing to get rid of proteases. So it might decrease the cytokine signaling, but it doesn't get rid of the proteases that are trapped in the joint. Because remember, your joints are avascular, so those proteins cannot get out of the joint once they're in there.
Right.
Okay, and they're like little termites eating away at it. The other problem with NSAIDs is they also work on the COX-2 pathway, which is the pathway how you rebuild cartilage. And we have to keep in mind, the cartilage in your knee today wasn't the same cartilage that was there a year or 2 years ago. It's always rejuvenating, regenerating. Now, as we get older, that process slows down. Right. But even if you're 70, the cartilage in your knee isn't the cartilage was there when you were 65. So just keep this in mind.
Yep.
But those proteases, when they start to eat the cartilage quicker than you're regrowing it, that's when you have arthritis.
Right. And so the NSAID is actually, is the NSAID actually slowing that process too? So
slows the cartilage growth process down because it works on the
Right.
COX-2 pathway, which is how you grow cartilage.
Which is so counterintuitive to everyone that comes in. All of our patients that come in have been taking ibuprofen like candy. And I can tell people all the time, you've literally told your body not to heal.
Correct. Now, if you have a headache, take an ibuprofen. If you stub your toe and it's killing you, take an ibuprofen.
Right.
But those are designed for short-term use only, 2 or 3 days.
Right.
So I'm not anti-medication. I don't want this to be taken that way. If I stub my toe and it's throbbing, I take an ibuprofen. I have no problem with that. But if I have toe pain that hurts me for a month and I'm still popping ibuprofen, I'm accelerating the arthritic process.
Right.
On top of kidney issues, gut issues, which is a whole other plethora.
Yeah.
And I think that people have the misnomer. You can go to Costco and they sell ibuprofen in bottles bigger than this. So people assume it's over the counter. Oh, sorry.
Yeah.
It's over the counter. It's safe. You must be able to take it forever. If you read the label, the first thing that says label, do not take long term. Even though they sell
everyone
it.
Skips over that. Everyone skips over that line, right?
Right. Well, you don't read it because people assume over the counter safe.
Yes.
My vitamin C comes in a big bottle, so I can take that every day. Ibuprofen, I can just take it every day too. You can't do that because you're speeding up arthritis not only in that joint, but everywhere your body grows cartilage is going to slow down.
Right. And people have no idea about that. So it's a great lesson. But all right. So proteases eating the joint. Yep.
So basically, remember we talked about, so you have these proteases, little termites in your joint that are released by the body, and they're trapped because as we get older, now if your kid's 14 and hurts his knee and releases proteases, they cycle out of the joint.
Correct.
It's when you get older, they get trapped. That's why young kids don't get arthritis.
Correct.
Unless it's rheumatoid, which is autoimmune, separate conversation. We're not going to go down the autoimmune pathway. That's another podcast. But you don't see young kids with arthritis because the proteases never get trapped in the joint, so that's not a non-issue. It's when you get older.
They have the great blood supply in and out, but as we get older, we don't have that great blood supply in and out.
Correct. So those proteases are trapped in the joint, and there's no way to get those out. And another option people do is they might do a cortisone injection or a steroid injection. That's like the next. So if you take Advil for a little while, your back or your knee still hurts, go back to the doctor. Hey, we'll give you a steroid injection, which is even worse than NSAIDs. Because each time you get a cortisone injection, it literally causes cartilage damage, up to 7% of bone loss, mineral loss, cartilage loss.
And that's every injection. That's every injection.
Each injection.
So let's review, because you're reading people's mail right now, Dr. Buzz. You're every single patient that comes in, they have some knee pain, or we'll call it knee pain. We'll stay on the knee. They start taking their ibuprofen. And that works for a little while, but they keep taking it, and they all of a sudden it's still bothering them. They go to an ortho. The ortho tells them, "Hey, you got a little bit of arthritis, but it's not too bad yet. So let's just give you some cortisone." And we've identified so far that the cause of the arthritis so far is the proteases. And the ibuprofen isn't doing anything about the proteases. And then they go to their doctor, and we've talked about this check engine light. They go to the ortho, and the ortho, rather than fix the problem, they're putting something to cover up the check engine light. They're giving them this cortisone shot, which you just said, once again, does nothing about these proteases. And it actually causes further deterioration of the joint and the tissues because of the nature of the cortisone. And so,
and think about this. If you think about it, that's why you're only allowed to get 3 injections per joint per year, because that's up to 20%, 1% life. Someone would give you 4 cortisone injections. That's medical malpractice. The amount of damage that happens. So think about that.
Right. Yeah, I literally, it's so funny that you say the 3 per year. I have a new patient that's going to start with us tomorrow, when we did our pre-history on them. And he said specifically, I get my 3 injections per year. Yep. And that, he's not getting 4, so it's not malpractice yet, but he's getting all 3 of them currently. Yep. And so again, the whole system of what people are used to is not addressing the root cause of the problem, these proteases. And so this is where the A2M comes in, I believe.
And I do want to discuss one other thing that's pretty typical. Great. So then you do your 3 cortisone injections. Yeah. And then after that, then they might approve you for hyaluronic acid injections.
Right. Yeah, let's talk about that. Yeah, we have patients that get that.
So, and basically what that is it's synthetic hyaluronic acid, which kind of mimics synovial fluid, but it's always temporary. So that doesn't cause any damage.
Sure.
Which is doesn't do anything with proteases. It doesn't do anything to stimulate cartilage growth. So it's like putting a temporary cushion in there for a little bit of time. And the feedback you'll get every time, I did a Synvisc injection and it worked for a month or a week or whatever. Like it lasts everyone different, but it goes away. Correct. So then you got to go do another one. And usually your insurance will cover whatever policy you have. Yeah. It might cover 1 injection, it might cover 5 injections, but it doesn't cover them forever because they also know it never works long term. Right. You'll never talk to someone who got a hyaluronic acid injection and say, "Hey, it fixed my knee pain." Never. Yeah.
It's so temporary. Amazing to think about this. And when you outline this process and how each of those particular tools are working, they always end in a knee replacement.
Because you've done nothing to stop the process. If you have termites in your house and you don't call the terminator, eventually, unless you sell the house is done. So the same thing, if you don't get the proteases out of the joint, you will have to do a replacement of the joint at some point. It's not if, it's when. Right. So now with A2M, we have the ability to stop the cause. So let's go back to A2M. So A2M, alpha-2 macroglobulin, is in your blood. It's a protein in your blood. And as I had mentioned, it's the largest circulating protein in your venous system. But it's so large, it can't get into your joints. Yes. So what we're able to do, I know we do in our facilities, and I know your clinic is we have a lab
since hearing from you, we do this as well. Yep. Mm-hmm.
Yeah. So we take a person's blood. So we take your blood or the patient's blood. We put it in our lab, and there's a process where we can extract that A2M protein out of that person's blood, and then take it with a small gauge needle, like an acupuncture needle, and put it into the joint. 'Cause there's no other way it's going to get there. It's not going to miraculously get from your venous system to your joint. Because remember, your joints are avascular. There's no circulation. Right. But if we take that from your blood, concentrate it down, and put it into the joint, A2M binds and breaks down the proteases. So you're literally stopping arthritis at the molecular level. That's the only cure.
That is the most exciting thing. When I heard you speak on that a year and a half ago, is, we were doing other biologic treatments, and we can get into some of those a little bit later. And we were seeing some really good results. But when you showed that science with us and shared that with us, that the only thing that stops arthritis, even all these other good things that we're doing, the only thing that stops those proteases is this A2M, this alpha 2 macroglobulin. That's what is enough to convince us to make this a part of our treatment plan as well.
Yeah, and unfortunately, there is some skill involved with it, right? Like it's a
Right.
procedure,
It is a procedure.
and it's very inexpensive, so it's not
Yeah.
really been adopted, and most insurances won't cover it because you can't patent it, so there's no
Right.
big money behind it.
Right.
So even though it's the most efficacious treatment, most people don't do it because it's work. It's hard for
It
your
is
office
work.
to do it.
Yeah.
It probably takes half hour, 45 minutes in the lab
Yep.
to make it.
Yep.
You got to draw the blood out of people. It's much easier. Let's give you a steroid injection. Let's give you a hyaluronic acid injection. Let's just replace your knee because there's big,
Yeah.
not that doctors, there isn't economics to this
Right.
at the end of the day. And,
Right.
if a knee replacement probably reimburses the surgery center, they don't make a lot of money on the replacement, maybe 3,000-4,000. But the facility fees, depending on your insurance, could be $20,000-$30,000 for that procedure.
Right. Right.
So there's where, an A2M procedure, anyone can afford it.
Right.
Because it's just not that expensive to do,
Correct.
and it's probably it's more work. It's much more work than a hyaluronic acid injection, much more work than a steroid injection. So it just hasn't been broadly accepted because of that.
Yeah,
it
and I
never will
think
be accepted. It's not a drug. It's from your own body. It's natural.
that's a very common question we get for patients. That if this is so effective, why isn't the ortho doing it? And you beautifully just outlined that. Is it comes down to reimbursement, and it's number one. Unfortunately, that is something. There's economics in medicine, but the work, like you said, when a patient comes in, we're scheduling, they're going to be in the office that particular day for 30, 45 minutes because we do draw blood, we spin the blood, and then we filter the blood to get the A2M. So it is a process that we have to, as the team, go through to basically harvest this A2M out of your blood and re-inject it. And that's kind of how I describe it. And I kind of describe it to the patient that we're biohacking the body. You have the A2M within you. It just can't get to the right spot right now. And so we're helping you. We're taking it from your blood, circulating your blood. We process it and give it back to you. And it's the results have been amazing of using A2M. Even unlike the other biologics that we do, is within a short amount of time, a couple of days, people are seeing that decrease in pain. Obviously, we're not seeing changes.
Because it also binds with cytokines, just so you know. That's why.
That's cool. Yeah.
So even though the pain's getting better,
yeah,
they're not fixed. Yeah, because
yeah,
whenever you're doing regenerative medicine, it's much different than traditional medicine, because traditional medicine really focuses on, let's just get rid of the pain. Let's put the duct tape over the check engine light, which has nothing to do with anything. Mm-hmm. With regenerative medicine, you're literally trying to stop degenerative process and regrow tissue. It's kind of like a garden.
Yeah.
So, I like to use the garden analogy. So if you had a flower garden, and, the flowers are pretty, and all of a sudden you get a bunch of beetles in there eating the flowers. That's what the proteases are. They're in there, they're eating your flowers. Yep. So as a gardener, you have a choice. You could, basically take a bunch of fertilizer and say, man, I'm going to get these flowers to outgrow the beetles so I have my flowers. And that's what using like PRP or umbilical cord extract or other orthobiologics. And that's not a wrong choice.
Yeah, and we use those as well.
If you can get enough anabolic effect to overtake the catabolic effect of the proteases, you can buy that person time.
Yep.
But even the umbilical extract, double spin PRP does nothing to get rid of the proteases. They're still there. Correct. So eventually, if the beetles are there, the fertilizer effect wears off, you're back at square one. So if you don't get rid of the proteases, and the only way to do this with A2M, there is no permanent solution to arthritis. It's that simple.
And that was the click. During a year and a half ago when you met and you were speaking on it, is we had been doing the PRP and the other umbilical products and been getting great results. People get good relief. But when you said that even those powerful products were not stopping the arthritic process, they were not exterminating the beetles, to use your analogy. But we could. There's a way to exterminate the beetles. We can use the A2M first and then follow up. We actually will do a follow-up 8 weeks after the A2M injection with the umbilical products. So you not only are giving the body what it needs to heal and regenerate tissue, but you're actually stopping the source of the degeneration also. Like, it's almost becomes a no-brainer of, well,
Well, you go back to the garden. So you
Right.
have beetles in the garden. So step one is we got to kill the beetles.
Correct.
But then step two, if you add fertilizer, the flowers grow back better than ever.
Right.
So, you do A2M first, and then we also both use peptides. So,
Right.
peptides help the healing process. So we use, the iontophoresis peptides.
Yeah.
You can use PMF therapy, laser therapy, decompression therapy. All these therapies help to grow it back. And then you add additional fertilizer, either double spin PRP or umbilical extract or other orthobiologics, to put fertilizer to grow the tissue back once you get rid of the cause of why it was gone in the first place.
Right. And I
That's
love
a permanent solution.
correct. And I love that's how you tailor back is the approach to regenerative medicine versus typical orthopedic care are completely different paths. Like we've kind of talked about, unfortunately, the typical orthopedic path is to just cover up the pain, which, for a lot of us, if you're in a ton of pain, sometimes pain relief is wonderful to have, but it never gets to the root cause of the problem and eventually always ends in surgery. Where regenerative medicine is we're actually trying to get to the root cause of the problem and then actually see if we can solve the problem also, utilizing these tools we're discussing. And so it's just a mindset shift for people. They don't understand what we're doing sometimes. And, if I can just go in and get a cortisone shot, why not do that versus, this process. So it's been fun to see. And you actually touched it briefly there on peptides. We have started utilizing peptides in our care plan too. I think, I'm super excited about peptides. Can you just maybe even just start off telling the audience what peptides are, and we're using particular BPC-157 as our main peptide within physical medicine and musculoskeletal care. That seems to be the most popular one. But if you could give us an overview on that, that'd be awesome.
Yeah, really simply, peptides are just small chains of amino acids, usually 50 or less. If it's bigger than 50, then it's a protein. So these are very small chains of amino acids. And BPC-157 is particularly interesting because BPC-157 works on several mechanisms to help the healing process. The first thing it does is it promotes angiogenesis, which improves circulation. And remember, things that don't have good circulation never heal.
Right.
So anything you can do to help improve circulation on an injured area is going to help that area heal better.
Right. Increase blood flow, get the capillary blood flow, get the nutrients to the joint. Yep.
Correct. And it's very powerful at that. It also modulates cytokines. So basically, remember, the cytokines are the things that cause pain. So it helps slow down the body releasing those cytokines because the body's healing. Right. So people feel better. They get out of pain when they use BPC-157.
Yes.
And then the final thing it does, a lot of people don't realize this, but a reason a lot of people have pain everywhere and aches and pains everywhere, the older we are, the more likely we're likely to have this thing called leaky gut. And basically what happens is your gut, due to parasites, bugs, plastics, there's lots of environmental factors. That's probably another podcast we can do.
Yeah, right.
Your gut, literally, the mucosal lining starts to thin out. And then when you eat things, in particular proteins, it literally leaks out of your gut and leaks into your bloodstream. And the problem with that is when the proteins end up in joints or other areas, your body doesn't know what they are. So the body attacks them, creating inflammation, which causes you to release cytokines, which causes you to release more proteases. So anything you can do to help mitigate leaky gut, which BPC-157 does an amazing job of, will get rid of systemic inflammation. So like if you're using the BPC-157 patches on a knee, people will say, man, my shoulder quit hurting, my stomach's not upset anymore, because it does go systemic, but we use it to treat a certain area, but there'll be systemic benefits because of all the other things it's doing.
Yeah, and it happens all the time. As we are a patient comes in, we're treating a particular tissue or typical a particular joint, but we start using the whole process and using the patches, and like you said, they mention so many other areas of their body that are starting to feel so much better because it is systemic. And let's touch on the difference between the mechanism of how we're delivering the BPC-157 versus other options, and even the quality. I guess peptides are becoming very popular, and you can find them. You can do a Google search on BPC-157, find all kinds of information. Probably even find places that would sell you them. But because of it's the Wild West kind of, maybe not fully, but like you can get them from, Joe Smo could go online and probably buy some right now. What is the risk or the benefit of buying them online or making sure they're from a reputable source? And then we could even get then into the delivery system as well, because I love our delivery system in the patch form versus the injected form. So if you
Yeah,
could touch
so
on those differences.
BPC-157, there's three ways you can get it. There's orally available. I think you can buy it on Amazon.
Mm-hmm.
The huge problem with the oral is it has very poor bioavailability. Remember, these proteins are very delicate, and when they reach the gut, they break down. So I do think taking BPC-157 for like specific stomach issues would be fine, but it never gets past the stomach to large and small intestine, and that's where a lot of the leaky gut happens. Okay,
Right.
so BPC-157 bioavailability is, and the research I've read is less than 10%. So unless you're taking like a bottle a day, you're
Right.
probably not going to notice a difference. So I don't recommend that. You can inject it, and injectable does work, but that's where the conversation comes up. You got to be careful of your source.
Correct.
The vast majority of these peptides, there's lots of solvents used in the manufacture, and most of them come from China because there's less regulations. So when we've tested lots of different brands, and we source the rare molecules, and we used to get them from Europe now because we could not find a dependable source in China because they either had high solvent content, they weren't strong, they're very delicate, they're very complex to make. So I would just warn you, if you're buying injectables online and there's lots of solvents, and the ones we tested were heavy with solvents are neurotoxins, not advisable. So just make sure that if you're getting BPC-157, get it from your physician the way I recommend,
Right.
and make sure that they have the testing to prove it, the purity and the cleanliness of it. Because if you're taking something that's solvent heavy or it's not even real, you're wasting your time.
Right.
Okay. Now, the issue with injecting, though, is BPC-157 has a very short half-life.
I was just saying.
And a half-life basically is how long something has an effect on the body. So the BPC-157 half-life is about 4 hours. So that means if you inject, we'll say 300 micrograms of BPC-157, 4 hours later, you're getting the dose effect of 150 micrograms. 4 hours later, you're getting the dose effect of 75 micrograms. And there's 5 half-lives. After 5 half-lives, it's out of your system. So it's only affecting the area for a very short period of time. Now, iontophoresis is the way that we use in our practice, and you do also. Iontophoresis uses electric energy to push molecules through the skin without a needle. So think of it as a needleless delivery method, which, number one, that's nice because it doesn't hurt, right? And you're not sticking yourself. But more important than that is when you wear the iontophoresis patch, instead of that short half-life, it's going to dose you a high dose over 12 hours. So that means it's affecting the joint and affecting the body for 12 hours plus, instead of 4 hours you're getting a decent dose and then it really tapers off after that. So you get a much better TUD, or time under dose, or cellular effect. So that's why for any of the peptides, and most peptides have very short half-lives, iontophoresis is the best method to deliver them.
Right. And it's been so comfortable for patients to do, and it's so easy to do. So just to kind of paint the picture for the audience here, it looks like a big Band-Aid, and it comes with a vial of dry powder and a little tube of water, and you just add a little water to it and make sure it dissolves, and you pour it onto this big Band-Aid looking thing, and you stick it on your skin. And you leave it there for 12 to 14 hours, depending on the pad that we have or the patch. And like he described, it just absorbs into the skin and systemically helps the body do its thing. Patients love it. They're seeing results with it very fast. It's just a great addition to our tool and our process for regenerative medicine, or quite frankly, we're starting to use it for nearly all of our cases. I mean, we're working in physical medicine, working with muscles and bones and joints and tissues all the time, all day, every day on every patient. So we use it on a lot of cases, not just on these regenerative cases as well.
It's amazing for back pain too.
Right.
People have chronic back pain. Those discs and facets in your back, which are the joints in your back, have terrible circulation. That's why back pain becomes very chronic. And remember, chronic pain leads to arthritis and degeneration, and eventually back surgery if you don't do something about it. But sometimes you're just using that BPC, and it also combined with the BPC, we also include NAD with it, which is another peptide that is important for mitochondrial function, which basically means it makes your cells function better. NAD is like a really hot button right now. You hear about it.
Huge.
It's huge because it's one of the few supplements that you take that you notice a difference. Like if your NAD levels are depleted, And most people, by the time they're age 40, your NAD levels are about half of what they were when you're younger. NAD is the coenzyme that makes your mitochondria or your cells work. So the less NAD, the slower the cell works. That's why your metabolism slows down with age. That's why healing slows down with age. So when you take NAD, you speed up cellular metabolism. You speed up all healing processes and metabolic processes. So the combination of BPC with NAD in that patch speeds up the healing process.
Right.
And you get them both. And NAD has even a shorter half-life, less than an hour. So you can go do an NAD IV, but it's in and out of your system pretty quickly. Why not dose the cells for 12 hours plus and speed that healing process up? It just makes total sense.
Yeah, and I think this is where information from the appropriate source is so important, because like you said, NAD is a hot button right now. I've seen it online. You can get in a pill form, which we've discussed. I mean, NAD is not bioavailable.
You cannot get NAD is not orally bioavailable.
Yeah.
There's people that take something called NMN, and sometimes they'll label it as NAD. But the problem with NMN is, number one, you're depending upon your body to break that down and get it into the cell, and depending on your health level, that may or may not work. But more importantly, NMN only increases intracellular NAD levels, potentially, not extracellular. And the extracellular is the majority of the benefit.
Right.
So then you're back to, you can't take it orally. You can do an IV, but the IV is, to get 500 milligrams, you have to be on the IV for 3 hours, because it has such a strong effect on the mitochondria that if you do it too fast, like, you get heart palpitations and stuff. You don't want that.
No.
But with iontophoresis, you can get, I think we put 250 milligrams is with the BPC. If people really want to feel it, we have just a straight NAD patch where you're getting 1,300 milligrams over 12 hours.
Yep.
Like, when you take that stuff, like, the energy level you have, I always tell people, as we age, you have to decide in life, as you age, are you just going to be cool with aging and kind of feeling tired and having aches and pains, and like, it's kind of, if you have a car. Yep. Some people buy their car and they wax it and they change the oil and they put new tires on it, and the car lasts a long time, and it's still, like, I have a 67 Camaro that looks brand new. You could eat off of it, but that's a lot. It's work. It's not as easy as my Tesla. That's easy, right? Plug it in and whatever. Right. Or you say, I'm going to buy the car and just run the hell out of it, and when it breaks down, whatever. Right. Your body's the same way.
But it was, what's interesting what you said about the NAD component is that you will feel the difference. And the comment I will give on that is, I do a lot of things for my health. I'm the guy that's trying to wax and polish his car. As far as when it comes to my health, I do a lot of things right. And so because of that, so many times I'll take a new vitamin or try a new supplement. And I'll be honest, most of the time I don't feel a difference. I just did it. I did an NAD patch this past Sunday, and it was amazing. I could actually physically feel that I had put that on and felt the energy. And so that is one thing that I've done where I actually noticed the difference. So that was pretty cool experience. But if we could shift back to the A2M real quick. We talked about it treating arthritis. And I'm asking this kind of for the audience, not necessarily for myself, but so is A2M limited to just like joints like knees and hips and shoulders, or can it be used for the spine as well, or how does that work?
Yeah, you can use it anywhere where you have chronic pain, because if you have pain, you have proteases. Right. Now, from my experience, I do think that the most profound effects I've seen is in joints, because in joints, the proteases are literally trapped in those capsules. Correct. So shoulders, fingers, a lot of women have thumb arthritis because, they're working with their hands a lot. And guys can have that too. Like profound effects. Like people, and just because, and you also have to keep in mind here, I can't tell you, probably half the people we do A2M on that we get great results with have come to me and say, my doc said I have to replace my knee. I have to replace my shoulder. I have to have back surgery. So if that provider doesn't do the procedure, they can't. That's like me telling you you need to have a root canal. I don't know anything about teeth. Yeah, so like you wouldn't ask me, right? Or if you need, like I'm just the wrong guy. So you can't ask someone who doesn't do the procedures, should you do the procedure? Right. You need to find someone who does the procedure, because not everyone qualifies. I don't want to give people false hope. I mean, I turn people away all the time. If the joint is too far gone. Right. And I don't care, the rule of thumb I use, If I look at it on an X-ray and it's I hear bone on bone all the time.
All the time. All the time.
Yeah. So number one, if it was really bone on bone, your joint wouldn't move. So there's something there, because otherwise the joint wouldn't move. But if it on X-ray it appears very close, I don't care. Now, if the bone's chewed up and gone, if someone has the femoral head, the ball's gone, we can't grow back bone.
No.
Sorry. So you're not a candidate. You have to go get a metal one put in. Yeah. But if I look at your knee and the condyles are still there and there's no space, we can save that thing. If I look at your shoulder and the ball's still there, I don't care how close it is. If you're alive, you have the ability to heal. People have to remember this. Now, if you're dead, we can't work with you. But if you're alive and the bones are still there, we can work with you.
Right. And that's, we actually have a patient that's finishing up her protocol right now. And she was it's almost as a blessing, but she was not a surgical candidate for other health issues. And her knees were the worst I've ever seen. They're, as far as bone on bone go, they were the worst. And to the point where, positioning was important for the procedure and all of that, but we were able to get the needle in there. We were able to use the A2M, and she's getting results and feeling better. So it's been pretty cool.
And that's the case too, where you're using the peptides, and you definitely would want to use either like an umbilical cord allograft, because remember, in an older person, the tissue grows back slower. So once you get rid of the causing arthritis, you do want to promote tissue growth. And sometimes as we get older, we need some help. So that's where, the soil's older, right? It's not fresh soil. So let's put some good peat moss on top of it. Basically when you're putting either umbilical allograft or double spin PRP, that's just really good fertilizer. Right. So let's get rid of the cause and let's put the fertilizer in there to help the tissue grow back. That's all you're doing.
Right. So when you are treating the joints, and I explain this to the patient all the time, we're not injecting into the disc or all the way to the facets. We're in the paraspinal area. Can you explain that, how that works?
Yeah, because when you put these in here, they're going to disperse. Obviously, they're in liquid, and we're also using scaffolding, which I think is another differentiator that most physicians are not using. What you have to keep in mind, if your physician's injecting you with anything like PRP, A2M, whatever, if they don't make scaffolding with it and they're just injecting a liquids dissipate from the area within a few hours to maybe a day max. So you're getting an effect for a little bit of time, but it's gone. But what we've been doing is we make scaffolding, which is a gel. When we do A2M and PRP, we're just taking some of your blood and heating it, and it creates a gel and mixing it. And with the umbilical extracts, we're taking some of that and heating it, and then we're mixing it. That stays in the area for 3 to 4 months. Right. So it's more of a time release. So that prevents you from multiple procedures.
It's basically turning,
which is a huge deal. But it's more work, once again, so a lot of people don't do it. So now we're talking about maybe 5% of providers that even do regenerative medicine are only doing that. But it's a huge difference, because would you rather have the effects of the PRP, A2M, or umbilical extracts for 24 hours, or would you rather have the effects of it for 3 months? Correct. That's the difference scaffolding makes.
And I think that's a great point. I love the fact that you said only like 5% of even regenerative medicine, because a lot of times patients will compare us to different facilities, potentially maybe they're shopping around, and we do all of these steps. The hard work. We do the hard work on every single step of the process so that it's the best potential outcome for the patient. And that includes doing the A2M before we do the umbilical product. We want to extinguish the arthritis before we fertilize it. And then when we do all of the injections, we want it to last as long as we can in the area that we want. So we do the scaffolding, and it's really a neat process to watch. If you're kind of a science nerd, you take a little PRP and we put it in this little heater, and it looks like a little jello, and then we mix that with whatever product we're going to inject.
Makes it time release.
And it makes it a time release product instead of an instant, or not, over a couple hours release. It makes it a lot longer. So we've implemented all of these little tricks of the trade to just make the best outcome. And it's been fun to see the results that we're rendering from doing all that hard work. That's a great segue to, I know I want to respect your time, Dr. Buzz. I really appreciate what you've been able to give to us today. Potentially there's, future conversations to be had, but on the topics that we've touched on today, is there anything that you feel like we left out that we need to touch on?
I think the main thing I would say to people is it's very simple. The body always wants to heal itself, but sometimes it can't. But if you're alive, you have the ability to heal. Okay? So if you've been told you have to have surgery, or there is no hope, go see a regenerative medicine specialist. And the key questions I'd ask them is, what procedures do you do? If they just do PRP, that means you're not interested. Do they do PRP? Do they do A2M? Do they do umbilical extracts or birth tissue extracts or exosomes? Because if you went to a mechanic and he just had a hammer, that's not a good mechanic. How big is his toolbox? Do they have PMF therapy? Do they have these other things? All these things work. And it's the sequencing and it's the combination that really makes the difference. The more tools in the toolbox the doctor has, the more experience they have, the better results you're going to have. PRP is one I hear all the time. People say, I've already tried regenerative medicine, I did PRP. Well, once again, we'll say 90% of doctors who do PRP do single spin PRP, which basically, and if you're listening to this and you said, I've had PRP and it didn't work, single spin PRP. So a lot of people say, I've tried regenerative medicine. What I did PRP. So the first thing I would ask them, well, how much blood did they take out of you? Well, if they only take 1 vial of blood out of you, that's by definition is platelet poor plasma. It's not even platelet rich plasma, because the reason you do PRP is to get the growth factors from the blood to make the fertilizer to put it back into an area. So obviously, the more blood you take, the more fertilizer. It's kind of like if you're making orange juice. We could both make orange juice. You take 1 orange and mix it with a gallon of water, and that's orange juice, right? But does it taste good? No. Where the other person takes 10 or 12 oranges and does the same thing. They're both orange juice, but they're totally different. PRP is the same way now, and then when you double spin it, which takes double the time, that's when you go from single spin PRP. You may be concentrating at 1.2 to 1.3x. Double spin PRP, you're getting 10 to 12x concentration. It's that extra work that makes the difference. You get the dose effect.
Right.
Most doctors don't do it because it takes more time.
Right. And I'm glad you brought that up as far as what you're looking for in a regenerative medicine office. Because I'll be honest, you need an office that continues to look for more information, is continue to learn. Because when we started doing PRP, that's exactly what we did, unfortunately. We had the single vial.
I did the same thing.
And so that's where we started, but we didn't stop there. We always wanted to improve, and so we kept going to seminars and learned new things. And you're only at fault if you learn something and don't implement it. and so when we learned there was a difference, then we changed. We changed the tubes. We changed the process. We went from single spin with a better quality tube to a single spin to all the way to the double spin to make sure we're giving the patients the best product. But I think that's a good point. When you're searching for a regenerative medicine office is what products, what tools do they have? Are they differentiating the tools? Are they using different tools for different conditions? Or are they tailoring your care plan to you? Or are they doing the same thing for everyone? And that's what we try to do, is we try to individualize.
But there is no cookie cutter, that, right? And that's the difference. When you go to an office like yours, you have all these tools. I can have 2 x-rays of the exact same knee, and they might need different protocols because everyone heals differently because they're all individuals. There's no cookie cutter, so making sure your doctor has those tools in their toolbox, they have those extra things, and then they have the experience is all the difference. Because regenerative medicine works 100% of the time if you're alive. The body can heal itself. So keep that in mind. So if you're listening to this and you've been, I don't care what, your regular doctor said, because that's like asking me for a root canal. Go see somebody who has a big toolbox, who specializes in regenerative medicine. And as I said, you don't accept every patient. I don't accept every patient. Right. If I can help you, I'll let you know. And if you're too far gone, then you're just too far gone. I have no problem with surgery in those cases. Right. I'm not anti-surgery. I'm not anti-medication by any means.
Right. I think that's a great spot to be. And we're going 45 minutes here. So thank you so much for your time. I think this will be hugely valuable to our audience. And once again, thank you. And I hope that maybe we can have you on again sometime.
Hey, it was awesome. Thanks, Josh.
Thanks, man. I appreciate it.